Hello, my name is Dr. Nga and I am an anatomical pathologist at the National University Hospital in Singapore, as well as the National University of Singapore. And today I'm going to talk to you about salivary gland cytology. We will focus on the Milan system of reporting salivary gland cytopathology and its application. So first, I will take you through the diagnostic categories in the Milan system. Then we will look at some international literature on the performance of this system. And finally, we'll look at a few cases where we can actually apply the Milan system. So let's start off with the Milan system. And this came about by participation from an international panel of expert cytopathologists. And the first publication came out in 2018, followed by this book, which explains in great detail the application of the Milan system. And this is sponsored by the American Society of Cytopathology as well as the International Academy of Cytology. So this is a practical classification system which is evidence-based, and it lays out a system for standardized reporting. It stratifies the cytologic diagnosis specifically into different levels of risk of malignancy. It facilitates a management algorithm as well as quality assurance review and clinical audits. And we can see this when I present to you some of the results in many international audits using this system. So it is a 6-category diagnostic system, and the first category is non-diagnostic. The second is non-neoplastic. Category 3 is atypia of undetermined significance. Category 4 is quite interesting because it is split into 2 parts, and this is the neoplastic category, where we have benign neoplasms or we have salivary gland neoplasms of uncertain malignant potential or SUMP. Then category 5 is suspicious for malignancy, and category 6 is malignant. The authors stress that the reporting system should emphasize risk stratification rather than specific diagnoses. So we're going to look at the categories one by one, and we'll start off with the non-diagnostic category. A non-diagnostic salivary gland aspirate is one that for qualitative or quantitative reasons provides insufficient diagnostic material to provide an informative interpretation. So in order to diagnose this category, all cytologic material must be passed. There should not be any residual material that hasn't been processed for cytologic evaluation. The estimated rate of incidence should be up to 10%. There is no established specific criteria for adequacy, unfortunately, but the authors have put forward a quantitative criteria which can be used as a general guide, which is less than 60 lesional cells. And you may recognize that this is actually similar to that has been mentioned in the Bethesda system for reporting thyroid cytology. Qualitative reasons can also be present for a non-diagnostic aspirate. For example, if the slides are poorly prepared or if there is marked artifact that precludes accurate evaluation. So some cytologic criteria would be if you only see non-neoplastic or normal salivary gland elements, but there is a clinical setting of a discrete mass. So of course, the implication here is that there has to be some clinical and radiologic correlation. If there is a cystic lesion where you only get non-mucinous, non-specific cyst contents with no epithelial component. And some of the exclusion criteria are if it is a cystic lesion, but we do see mucin. So mucinous cyst contents, even without the presence of epithelial cells, the Milan authors suggest that this actually be categorized as atypia of undetermined significance because of the potential possibility of low-grade mucoepidermoid carcinoma. If there is any significant cytologic atypia, again, this should not be classed as non-diagnostic, but rather go into the AUS category. And if there are abundant inflammatory cells, even without an epithelial component, this can be classed as benign and called an inflammatory lesion. Also, if there are matrix components, for example, fibrillary stroma, that may suggest a neoplasm even in the absence of epithelial cells. Again, this should not fall into the non-diagnostic category. The management is repeat FNA under ultrasound guidance. And if the repeat FNA is still non-diagnostic, then definitely imaging can be recommended. If there are any features that are concerning for malignancy, clinically or radiologically, an ultrasound-guided core needle biopsy, histologic biopsy may be suggested, or even an open biopsy or surgical excision. In the context of cyst contents only, the recommendation is to aspirate completely under ultrasound guidance, and of course, also targeting any solid areas that are residual. If the cyst disappears completely, then one could recommend repeat ultrasound with or without FNA after an appropriate interval, about 3 to 4 months. So again, you can see that the recommendations depend on the clinical context. The next category is nonneoplastic, and this is defined as specimens that show benign nonneoplastic changes, including those associated with acute or chronic reactive responses to inflammation, structural alterations, and infection. It is used in conjunction with available clinical and radiologic information, and management is to follow up with or without imaging or repeat ultrasound-guided FNA if required. So some clinical context or some examples would be inflammatory lesions such as acute or chronic sialadenitis, and the chronic inflammation could be in several different settings, for example, infectious or non-infectious, lymphoepithelial sialadenitis, IgG4 disease, etc. And sialolithiasis, sialadenosis. Again, this is very important because this condition usually gives rise to bilateral gland enlargement, and also in some specific clinical settings. Oncocytosis and reactive lymph node hyperplasia, meaning that what is aspirated is actually a lymph node rather than a salivary gland nodule. In the context of an elderly patient, or if the nodule is of significant size, or if there are multiple or matted lymph nodes, then flow cytometry can also be recommended. And you can see that a common thread runs through all these potential clinical settings, and that is clinical pathologic correlation. So for this particular category, it is extremely important to have an idea of the clinical picture. Now, moving on to the next category, AUS, and I have paraphrased the definition here. So this is where the aspirate lacks features for a confident diagnosis of non-neoplastic or neoplastic lesion, but it contains an atypical morphologic feature. So in other words, what it means is that there is some atypia and we cannot exclude the possibility of a neoplasm. Again, the entire sample should have been submitted for cytologic evaluation, and some likely outcomes could have been reactive atypia or a neoplasm that is poorly sampled. And the benchmark, one potential parameter that can be used for quality assurance audits, would be that this category should not exceed 10% of all salivary gland FNAs in the institution. So some scenarios, if there is poor cellularity, for example, there are some basaloid cells, but it's difficult to know whether these are native basaloid cells, for example, ductal cells, and we can't really tell whether it's sialadenitis or an actual basaloid neoplasm. If the preparation is suboptimal and hampers definitive evaluation, if there are some cytologic changes of perhaps nuclear enlargement, where we are not sure whether it is due to reactive atypia versus a neoplasm, and this is particularly so if there are metaplastic changes, for example, squamous metaplasia, oncocytic metaplasia. This can be seen in both reactive conditions as well as neoplasms. If there are few spindle cells seen, again, this is quite difficult because potentially these may be due to perhaps inflammatory conditions, or they may also arise from a neoplasm, such as a myoepithelioma or a schwannoma, etc. Other scenarios would be cystic lesions, and it's very important to recognize the significance of the presence of mucin. In a mucin-containing cystic lesion, the concern is always that it may actually represent a low-grade cystic leukoepidermoid carcinoma. So even if there are very few epithelial cells, the authors encourage these types of lesions to be classed as AUS. Lymphoid lesions are also particularly challenging. If there is a prominent lymphoid component, this could actually be due to just simple chronic inflammatory lesions, or perhaps a lymph node within the salivary gland or close to the salivary gland that is sampled. However, of course, lymphoid-rich lesions could also be due to lymphoproliferative disorders, whether they are in intrasalivary gland nodes or even involving the salivary gland, such as MALT lymphoma. Or they can be due to tumors with a prominent lymphoid background, such as Warthin, mucoepidermoid, or actinic cell carcinoma. So there's a whole range of benign and malignant entities which can be lymphoid rich. The risk of malignancy is approximately estimated to be about 20%, and later I will show you some actual figures from international studies. And the management is regular clinical follow-up with imaging studies, and in cystic lesions to aspirate any residual solid areas under ultrasound guidance. If there are any features concerning for malignancy, definitely further tissue samples are required, whether it is ultrasound-guided FNA or core needle biopsy, or even consideration for open biopsy. In the context of atypical lymphoid cells, flow cytometry may be suggested. And I will also mention later on that there are some ancillary tests, such as immunohistochemical tests, that may be of some use, and we'll talk about that later. Moving on to category 4, this is the neoplastic category, and again, I want to highlight that this is a little bit special because it is subdivided into two subcategories. So we have benign neoplasm, and we have SUMP, which is salivary gland neoplasm of uncertain malignant potential. For benign neoplasms, actually FNA has a very good high specificity for this, about 98%, but we have to see characteristic features that can give rise to a confident diagnosis of this specific benign neoplasm. And examples would be pleomorphic adenoma, Warthin tumor, oncocytoma. Mesenchymal tumors can also be diagnosed, lipoma, schwannoma, lymphangioma, which may be a little bit more challenging, and hemangioma. Now, for the second subcategory of SUMP, this is where we are sure that we are dealing with a neoplasm. However, we cannot distinguish between benign and malignant neoplasms. So therefore, usually the cells are well differentiated, which means we are looking at low-grade neoplasms, and the diagnosis of a specific entity cannot be made. So in other words, what it means is that we are saying this is a tumor, but we can't exclude the possibility of a malignant tumor, and it is usually low grade. There are three morphologic subcategories in this SUMP category. We have basaloid neoplasms, and examples of histologic outcomes would be pleomorphic adenoma or malignancy such as adenoid cystic carcinoma, epithelial myoepithelial carcinoma, and of course basal cell neoplasms, and also even some myoepithelial neoplasms. There may be a stromal component, and if there is, look very carefully at this because this is extremely helpful. And again, I will talk about this later. The second morphologic subcategory is oncocytic or oncocytoid neoplasms. And again, you can see benign outcomes, oncocytoma, Warthin tumor, malignancies, mucoepidermoid, secretory carcinoma, and myoepithelial neoplasms. And the third category is neoplasms with clear cell features, including benign lesions like PA, malignancies, actinic cell, mucoepidermoid carcinoma, epithelial myoepithelial carcinoma, and even metastatic neoplasms, and again myoepithelial neoplasms. You may notice that myoepithelial neoplasms are seen in all categories because they can have a range of morphologic features. The management for this category for benign neoplasms is usually surgical excision, and for SUMP, Perhaps if ancillary testing can be helpful in that particular morphologic category, this can be considered. Imaging, of course, and definitely also proceeding to excision with or without frozen section. Now, moving on to the next category, this is suspicious for malignancy, and these are FNAs where the cytomorphologic criteria fall short in quantity or quality for malignant diagnosis. And we should also try our best to specify the category of malignancy, whether we think it's a primary salivary gland tumor, whether we think it is a metastatic tumor, or hematolymphoid malignancy. The risk of malignancy, which is estimated by the authors, approaches 60%, but actually in many institutions it can be significantly higher than this. Cytologic criteria would be the presence of markedly atypical cells, perhaps with some background poor specimen preparation, or perhaps with a sparsely cellular smear in an otherwise benign background. Management is potentially ancillary testing, such as immunocytochemistry or molecular tests, imaging, of course, and definitely surgical excision. Moving on to the last category, malignant. This is where there is a combination of cytomorphologic features that either alone or in combination with ancillary tests is diagnostic of malignancy. We should grade where possible, even if we can't specifically type the malignancy. If it is obvious that the tumor is high grade, this should be mentioned. And we can type it also, of course, where possible. So the Milan System has actually divided malignant tumors into three big groups: the low-grade tumors, including actinic cell, secretory carcinoma, and epithelial myoepithelial carcinoma; high-grade tumors, lymphoepithelial carcinoma, small cell carcinoma, and salivary duct carcinoma; and those that are of indeterminate grades. So these include lesions which have a range of grades, such as mucoepidermoid and adenoid cystic carcinoma, and also myoepithelial carcinomas and carcinoma X, pleomorphic adenoma, and of course hematolymphoid tumors and metastatic tumors. So I want to highlight some of these entities here. And these entities that I have highlighted are the ones that generally are a little bit more challenging to give a definitive diagnosis on cytology. And you can see here that they tend to end up perhaps in the sump category. These tend to be more low grade, or perhaps even in the AUS category. And for salivary duct carcinoma, often we can't give a specific diagnosis on cytology, but we can definitely at least call it malignant, and it is often high grade. So management, of course, is surgery. The grade also helps to denote the extent of surgery and the local extent of the tumor as well. So definitely imaging is very important. So to summarize the Milan system, here are the 6 diagnostic categories with the added subcategorization of the neoplasm category. And you can see the management suggestions would be clinical and radiologic correlation with repeat FNA for non-diagnostic, clinical follow-up for non-neoplastic, repeat FNA or surgery for AUS, and surgery for anything that is neoplastic and above. We're going to take a quick look now at the performance of the Milan system. So we have actually performed a local audit in our hospital, and we reported this last year in cancer cytopathology. So we had a total of 1,384 cases, and we had 421 cases with surgical follow-up. So I just want to explain a little bit these terms. This OROM is overall risk of malignancy. This is essentially the number of malignant cases over the entire number of cases in this category, regardless of whether there is surgical resection, versus ROM, risk of malignancy, which is the rate of malignancy divided by cases that have been surgically excised. So I think we can generally focus on ROM for practical purposes. And you can see that even for our non-neoplastic cases, there are a significant number that actually turned out to be malignant. And these turned out to be some difficult, tricky cases in which there was a lymphoid component. In the AUS category, our risk of malignancy was approaching 30%. For benign neoplasms, it was very low. For some, about 17%. And suspicious for malignancy, 83%, and malignant, it was 100%. So I have presented here the estimated risk that had been included in the Milan System book, and we can actually compare these figures. I want you to pay special attention to the AUS category as well as the SUMP category. And we can compare these figures with actual studies. There have been meta-analysis that shows a malignancy risk in AUS about 34%, and some about 41%. So slightly different in AUS compared to the original estimated risk in Milan. And we can see that there is a range of risk of malignancy in the AUS category, but all surprisingly not too far apart, in the range of around 30% to 40%. And for the SUM category, the risk ranges from actually lowest, which was our institution, 17%, to about 45% compared to the original 35% estimated risk. These were our specific results for our AUS and SUM categories. We had AUS from 41 patients, and we had non-neoplastic final histologic diagnosis. We had benign neoplasms, of course, including Wharton tumor, which formed the majority of cases. And the malignant cases turned out to be, not surprisingly, low-grade tumors, mucoepidermoid carcinoma, low-grade lymphoma, and a couple of other malignancies. For the SUMP category, we actually had a disproportionate number of pleomorphic adenomas. This is probably due to a combination of sampling as well as interpretation. Perhaps we did not appreciate the stromal elements as well as we should have. And the malignant diagnosis, again, you can see here, generally included more low-grade malignancies, with the exception of one salivary duct carcinoma. Now we're going to look at some quick pointers in applying the Milan system. So first of all, I want to just briefly run through some important considerations in salivary gland cytology. So we should appreciate what cytology can and can't do. And I will also briefly mention some potentially useful ancillary tests. And after that, we'll look at 3 cases. So what cytology can and can't do: consider the few neoplasms that can be readily diagnosed on cytology. You may be surprised to know that there is a quite limited spectrum of neoplasms that can be definitively diagnosed on cytology, and I've presented them here. The benign ones include pleomorphic adenoma, Wharton tumor, and oncocytoma, which of course we would require some radiologic correlation because differential diagnosis is oncocytosis. In malignancies, also not that many: adenoid cystic, actinic cell, carcinoma X, PA, and any high-grade carcinoma, and any high-grade lymphoma. And consider the neoplasms that may not be readily diagnosed on cytology. So mostly these will be low-grade neoplasms, and including benign lesions as well as low-grade cancers, which fall into mucoepidermoid carcinomas, epithelial, myoepithelial carcinomas, which may have a basaloid appearance, myoepithelial neoplasms, benign and malignant, because the malignancies can be well differentiated, and we would really require looking at the tumor interface with the rest of the salivary gland, similar to the context of basal cell neoplasms. Secretory carcinomas, because the definitive cytologic features may not be so well or readily appreciated. And polymorphous adenocarcinoma, I think probably one of the greatest clues would be the location in the palate. Now moving on to ancillary tests. There are some immunohistochemical tests which may aid in the diagnosis of some tumors, but again, they have individual caveats. So for actinic cell carcinoma, DOC1 and SOX10 are quite useful. For adenoid cystic carcinoma, S100 stains the abluminal cells. Again, DOC1 is positive, and so is SOX10. But with regards to SOX10, it is important to note that it can also be positive in other salivary gland neoplasms, especially basaloid neoplasms. So caution has to be exerted here because basaloid neoplasms also include benign entities. And for low-grade mucoepidermoid carcinoma, there has been shown to be a gene fusion on fish, but again, this may not be readily available in many labs. For salivary duct carcinoma, androgen receptor reactivity may be helpful, as well as GATA3, which is also positive in secretory carcinoma. So there also have been some molecular aberrations which have been described, and again, it really depends on availability in specific labs. Some of these actually have immunohistochemical correlates which have been developed, but again, these have to be validated in your specific institution. A word of caution for IHC PLAG1, which has been found to be positive in pleomorphic adenoma, has also now found to be positive in other tumors, including malignancies. So caution has to be exerted here, adenoid cystic carcinoma and basal cell neoplasms. SOX10, while positive in adenoid cystic and acidic as well as secretory carcinoma, has also recently been reported in pleomorphic adenomas and basal cell neoplasms. And also even MIP-IHC, which is useful in adenoid cystic carcinoma. If I just bring you back to this table here, has also been reported in benign entities, including pleomorphic adenoma and basal cell neoplasms. So the general trend is that the longer an IHC test has been around, the more cross-reactivities will be discovered. So now we're going to quickly look at 3 cases, and we're going to directly apply the Milan system to these cases. The first case is a 59-year-old man with a left parotid swelling. And here is the representative picture. I only have one picture for this case, but what we can see are cholesterol crystals, macrophages, and some granular material in the background. This is not mucin, and we do not see well-preserved epithelial cells. So which category would you put this under? And the answer is non-diagnostic, and the diagnosis should be written as cyst contents only because we do not have mucinous material, we do not have well-preserved epithelial cells, so we cannot make a definitive diagnosis. For cystic lesions, there is a range of differential diagnosis, which includes nonneoplastic conditions like lymphoepithelial cysts, chronic sialadenitis with obstruction, which can give rise to mucoceles or mucus retention, neoplastic conditions, including benign entities, especially Wharton tumor, and malignancies, especially low-grade mucoepidermoid carcinoma. And it's important to note that perhaps unlike other organs like the thyroid, at least 1/3 of cystic lesions in salivary glands are neoplastic. Many of them will actually be benign, particularly Wharton tumor, but it is important to note that they may be neoplastic. So here is a very quick approach to stratifying or classifying cystic lesions. It is important in the first instance to look for mucin. If there are mucinous contents, then of course we would still look for the diagnostic epithelial components. Differential diagnosis would include mucoepidermoid carcinoma, especially if we see these cellular elements. If there are insufficient diagnostic epithelial cells, this will still go into the AUS category because of the possibility of low-grade mucoepidermoid carcinoma. In a non-mucinous cyst, we would focus again on the epithelial cells. And if we see epithelial cells but they are sparse and they do not immediately lend themselves to a definitive diagnosis, this can go into the AUS category. If there are sufficient diagnostic cells, then really the category depends on what we see. For example, if we see oncocytic cells and lymphocytes, this goes into benign neoplasm. If there are no epithelial cells and no mucin, this goes into the non-diagnostic category. Moving on to the second case, this is a 79-year-old man with a right parotid lump, and we can see here sheets of relatively uniform oncocytic cells with abundant cytoplasm and a background of lymphocytes. So which category would you put this into? And here comes the answer. This should fall into the benign neoplasm category because clearly this is a Wharton tumor. So I just wanted to use this case as a platform to talk briefly about the approach to oncocytic lesions. For oncocytic lesions or oncocytoid lesions, you really want to focus on the degree of atypia of the oncocytic cells and preferably with radiologic correlation. So if they're very bland and it is a diffuse or multinodular process, we are likely to be dealing with nonneoplastic conditions such as oncocytosis. If there is a discrete nodule or mass, then we are probably dealing with a benign neoplasm, and oncocytoma would be an important differential, or perhaps a myoepithelial neoplasm. So again, this just goes back to the cytomorphology. If the oncocytic cells are atypical, they show some nuclear pleomorphism, prominent nucleoli, etc., then it is safer to put these into the category of at least SUMP, if not suspicious or malignant, really depending on the degree of nuclear atypia. So you can see a whole range of neoplasms that can give rise to these appearances. Now, moving on to the last case, this is a young patient with a right parotid lump that is painless. And you can see the aspirate is quite cellular. There is minimal stromal material, but certainly a lot of uniform basaloid cells with scant cytoplasm and oval nuclei. So which category would you put this into? And here comes the answer. This would fall into the SUMP category, so this would be neoplasm, but SUMP. And the diagnosis can be written as SUMP basaloid neoplasm, excision recommended. The histology for this particular lesion turned out to be that of a basal cell adenoma, and you can see that there is no invasion into the salivary gland parenchyma. So a quick approach to basaloid neoplasms, there are many differential diagnoses in this instance. It is also important to consider the possibility of non-salivary gland lesions, such as adnexal tumors like pilomatricoma or basal cell carcinoma. If the tumors are indeed arising in the salivary gland, it is important to look for a stromal component because often it is the stromal component that actually helps to clinch the diagnosis. So I will not read through every entity here, but you can see that if there is an absent stromal component, it's a little bit more tricky to actually define. So this usually ends up just being called SUMP, basaloid neoplasm. If there is stroma, then one can look at the nature of the stroma, for example, the classical fibrillary stroma, melting cells into the stroma, or large stromal globules and cylinders, in contrast, in adenoid cystic carcinoma. So take-home messages for basaloid neoplasms. The main most common differential diagnosis would include basal cell neoplasms, which are either malignant or benign, basal cell adenocarcinoma, basal cell adenoma, cellular PA, adenoid cystic carcinoma. These would be the top three. We are often unable to distinguish between benign or malignant basaloid neoplasms because of the requirement of examining the capsule, so they often fall into the SUMP category. So let me give you an overall recap of what we have looked at today. And here again is the summary of the Milan System: non-diagnostic, non-neoplastic, and it's very important to have clinical correlation in this category. AUS, neoplasm, which is subdivided into benign and SUMP. suspicious for malignancy, and finally, malignant. So the threshold for surgery really starts at AUS. Some take-home points: consider salivary gland neoplasms in 3 groups. Tumors which are readily diagnosed on cytology, including benign tumors, which are thankfully common, pleomorphic adenoma and Wharton tumors, malignant tumors, adenoid cystic carcinoma, actinic cell carcinoma. Tumors which are not readily diagnosed on cytology, which would fall into some big groups such as basaloid neoplasms, and again, stromal characteristics are very helpful, myoepithelial neoplasms, and low-grade malignancies, and these tend to fall collectively into the SUMP category, or sometimes suspicious for malignancy. Cystic lesions, in which they are often neoplastic, and it is very important to look for mucin as well as the nature of the epithelial cells. And finally, to remember the possibility of non-salivary gland lesions that are masquerading clinically as salivary gland nodules, lymph nodes, entities such as nodular fasciitis, which often does actually occur in the head and neck region, and pilometricoma or other adnexal neoplasms. Thank you.